Craig, thanks very much. I appreciate the opportunity to speak here. I've probably spent more time at this podium than anyone just introducing speakers. So I'm on the other side of the coin today. So we're going to switch gears a little bit and talk about switch from a tissue that has that's full of air to a tissue that has no air, and that's the gut. So we know that this is one of the few places in the gut lumen is one of the few places in the body where there really is no air, there is no oxygen, and anaerobic bacteria will grow. So we've become interested in this really from years ago, broad questions about metabolism. And we were often surprised, in looking through the literature, we were often surprised at how little was known about overall metabolism of tissues that became inflamed. So our model disease, and I would say that many of these principles really apply to most inflammatory sites. The one exception may be the lung, and I think it's interesting to consider the role of oxygen in these metabolic processes, but the one exception may be the lung. But the disease that we're interested in and that we model in the lab is inflammatory bowel disease, so also called IBD. Consists primarily of two major phenotypes, Crohn's disease, in which Crohn's disease is a disease where lesions can occur from literally the top to the bottom, and many extraintestinal manifestations, but classically in the colon, skip lesions and very, very severe small intestinal disease. Whereas shown on the right here is ulcerative colitis. And ulcerative colitis is a disease which occurs predominantly in the colon and is predominantly in the distal colon. So two very different diseases, but a similar sort of pathogenesis. And as shown here, it's really a kind of a tripartite disease, both ulcerative colitis and Crohn's disease. So first, you notice that there are certainly genetic traits that contribute to this disease. Unfortunately, no single gene describes this disease. There are currently 250 different genes that have been implicated, primarily from GWAS studies. That's, I think, a caveat. As most of us know that work in any of the genetic fields, GWAS studies can be revealing but also very confusing. But there's now 250 different loci. That's probably as of yesterday. I don't know about today, but 250 genes, very complex heredity. We also know from multiple studies, including twin studies, that there likely is an environmental trigger. And this environmental trigger may be luminal antigens. One of the hottest topics in this field, as there are in many fields, is the microbiota. So certainly significant interest in understanding how does the microbiota shift during this disease? Is it causative or is it a result of the disease? And then finally, we know clearly that there are immune components. Th1 versus Th2 immunity, this was really one of the model diseases in understanding Th1 and Th2 immunity. And then most widely, one of the more widely accepted therapies for both Crohn's disease and ulcerative colitis is TNF antagonists. So clearly there is a component that involves likely a difference in immune response. And this has brought about, of course, a lot of interest from pharmaceutical companies. Currently there are more than 90 drugs in trials for inflammatory bowel disease. So taking that into consideration, if we take a more microscopic look at the disease and we contrast the appearance of these diseases to the healthy tissue. So on the left you see the healthy colon tissue in which you have these large voids which are goblet cells, these very well established crypts, and very few cells in the lamina propria. If you contrast that to ulcerative colitis shown on the right, a few things that you see. One is you get very dominant breaks in barrier. You see fewer goblet cells, and you see lots and lots of infiltrating cells. Now, ulcerative colitis is a disease that occurs from probably multiple episodes of acute inflammatory responses, as opposed to maybe the more chronic inflammatory disease. But it becomes a disease that is interesting to study from a standpoint of metabolism. Why is that? So The cell that you see here in the center of the screen, this is termed a crypt abscess. I'll talk about this in a second, but this is essentially a profound migration of primarily neutrophils that migrate from the lamina propria into the lumen of the gut. So remember that this is really the outside world, and large numbers of cells have migrated across this break-in barrier into the lumen of the gut. So we know from multiple studies that as the tissue becomes inflamed, there's a tremendous increase in energy demand for that tissue. The response to an inflammatory, to inflammation, as well as responses to infectious diseases, requires a quite significant increase in energy demand. We also know, and I will talk about this in a second, but leukocytes, in particular neutrophils, can use more oxygen per cell than any cell in the body, including cardiac myocytes. And I'll talk about this in a second. And then finally, the vasculitis that's associated with both acute and chronic inflammatory diseases decreases oxygen delivery to these tissues. So it made sense a number of years ago for us to begin to think about what is central to these metabolic processes, and is oxygen metabolism important, and does it contribute to this disease? So, for the last 10 years, we've been really trying to understand how is it that oxygen metabolism influences this disease process. So the first question is, are these tissues hypoxic, right? So one of the cardinal signs of a tissue is that it's red. So you would expect increased blood flow to these tissues, and then in fact they're not hypoxic at all. In fact, they may be hyperoxic. So we set out years ago to determine if this was the case, and we took advantage of this, this monoclonal antibody, which recognizes two nitroimidazole dyes. So these molecules, in particular, we've used EF5, but these molecules essentially are taken into cells passively, where they form a reactive nitrogen species that, under adequate oxygen concentrations, regenerate the native compound, exit from the cell, and pass in urine. However, in the presence of in the absence of oxygen, when oxygen levels are low, these molecules form a very reactive nitrogen species here that adducts with various macromolecules in cells, and with monoclonal antibodies can be localized to a tissue. So this antibody was originally designed to identify tumor targets that have hypoxic cores. So we took advantage of this in colitic tissue. So this is a mouse model, and first we're looking at a healthy mouse, and immediately this became interesting. Why? Because as you can see here, so shown in red is the localization of areas of tissue that have a PO2 of less than 10. The air you're breathing is a PO2 of 150. So the first thing you notice is that this is quite interesting from a perspective of just physiology, and that is the tips of colonic villi are actually quite hypoxic, even anoxic at the very tips. So realize this is the outside of the world, so this is the lumen of the gut where there is zero oxygen. But you see this gradient across the tip of the villi. So we have termed this physiologic hypoxia. And this actually has turned out to be important from the perspective of gene regulation. If you then look at this in an animal model of colitis, this is using nitrobenzyl sulfonic acid, you see here that first that the tissue architecture breaks down, but you see that this becomes much more intense and much deeper into the tissue. So indeed, you're enhancing a normal response, and indeed these tissues are hypoxic, or so using a terminology of inflammatory hypoxia. So at about the time some of these observations were made, we became interested in understanding what are the signaling pathways, and one of those signaling pathways elicited was HIF1 alpha, hypoxia-inducible factor. And you can see here just by Western blot that colitis is associated with a strong induction or stabilization of this protein HIF1. So HIF1 is a particularly interesting molecule. It has this a very dramatic post-translational modification. So in the HIF alpha subunit, there are two proline groups which become hydroxylated, and under under conditions in which these prolines are hydroxylated, this molecule gets targeted to the proteasome for degradation by the von Hippel-Lindau associated EB3 or E3 ligase. When oxygen is no longer available under hypoxic conditions, these hydroxylases are inhibited, and hypoxia then results in the stabilization of this protein, translocation to the nucleus where it binds to HIF-1 beta and drives the transcription of multiple genes. So this is an interesting and a particularly relevant molecule. In fact, just this week, the 2016 Lasker Award was given for HIF. Greg Semenza at Johns Hopkins discovered HIF. Peter Radcliffe discovered the prolyl hydroxylases. These molecules here, where's my pointer? Yeah, these molecules here. And the von Hippel-Lindau protein was discovered or realized by Bill Kalin at Harvard Medical School. So you'll see more and more of this now as this gets pressed. So then coming back to disease, we asked the question: is HIF stabilized in IBD, in bona fide IBD? So here, in collaboration with Ed DeZoten at Children's Hospital, we took a pediatric cohort, in this case 25 normal samples and 25 samples of patients with either mild, moderate, or severe disease. And in this case, we had a pathologist score these tissues, and we measured HIF, stabilized HIF, in these pathologist-graded samples. And what you can see very nicely here is that with increasing severity of disease, increased stabilization of HIF. In particular, in the severe, in patients with very severe disease had very high levels of HIF. So you could then say, well, this is associated with disease, it's pathological, and this becomes essentially a target for inhibition. So is that really the case? Well, it turns out that this may or may not be the case. So one of the things you notice here with these very severe diseases is the accumulation of large numbers of neutrophils, as I mentioned in the first slide. So this becomes a biomarker then for inflammatory disease. So again, this is a tissue from a patient with ulcerative colitis in which large numbers of neutrophils have migrated into the lumen of the gut. Now, the crypt abscess, as it's termed, is really a biomarker. It's transepithelial migration. This is determined very interestingly from essentially the anatomy of the gut. So this is a vascular cast that was done a number of years ago and demonstrated that, in fact, at the crypt, at the base of the crypt is where leukocytes move through the epithelium, or move into the epithelium. And this is because of the expression of specific markers or zip codes on the endothelium at the base of this crypt. It's a hallmark of inflammatory disease, and as we've shown, it correlates with disease severity. So, are these good guys or bad guys? So you get asked that question in a very fundamental way. We've come to believe that this is a good guy, and I'll tell you why in a minute, but we weren't the first to discover this. So before Google, let's say, there was a gladiatorial surgeon named Galen of Pergamon, and he had described incidents of in the Roman gladiator periods, those patients that formed pus, those patients that had leukocytes in their tissues, in fact, were the ones that healed their tissues. Those that did not heal and did not resolve. And he made this observation and became very famous for his statement of good and laudable pus. Unfortunately, he fell from favor when he began to introduce foreign objects into tissues to induce pus, which was the first description of sepsis. So Rick Campbell, who started off as a postdoc and is now a junior faculty member, he's actually spoken at this conference before, but Rick Campbell had this very provocative hypothesis a couple of years ago, and he proposed that the hypothesis that an active inflammatory response is protective in the mucosa through its actions on HIF-dependent pathways. So at the time, this was, I think, a pretty provocative and in some ways a little bit of a crazy idea, but as you'll see, this actually turned out to be really an important observation. So what RIC proposed was the following, that activated neutrophils, I mentioned to you that this is a cell that can utilize oxygen at a higher rate than any other cell, and that activated neutrophils become localized and become an oxygen sink. That the depletion of oxygen associated with this migration results in the stabilization of HIF. So how is it that a neutrophil uses so much oxygen? In fact, it makes superoxide anion. The way that a tissue the way that a neutrophil kills bacteria, its primary function is through the 2-electron reduction of oxygen, molecular oxygen, through the NOx2 complex, molecular oxygen through superoxide anion, hydrogen peroxide, and then ultimately to bleach. And this is how you kill bacteria. And this is a very, very active system. So to cut to the chase, Rick had done the following experiment. He depleted leukocytes using an anti-GR1 or Ly6G antibody. So we could deplete neutrophils, circulating neutrophils from a mouse model. We could deplete neutrophils by about 90%. What he did then is induced colitis in these animals, and he used, in this case, a HIF reporter mouse. So any place you see green is the expression of HIF. You can see it localizes in active colitic disease very, very prominently to the apical or luminal surface. A vehicle animal, you see some localization here, but very little in this case. So what happens if you deplete neutrophils from these animals and induce colitis? So essentially this experiment, without neutrophils, you see essentially no stabilization of HIF. One of the more dramatic responses, one of the more dramatic observations that we've seen. So you see very prominently that neutrophils are a predominant pathway for the elucidation of HIF. So again, coming back to the question, is this a protective mechanism or is this a pathological mechanism? So you can see very nicely here that localization of HIF, this is by immunohistochemistry. You can see here very nicely that the localization of HIF within the epithelium is dominant compared to control patients. So to do this, we developed a mouse model in which we knocked out intestinal epithelial HIF, 1-alpha in this case, and proposed and essentially performed an experiment where we elicited colitis in these mice. And at this point, it really was an experiment. We did not know what the results would be, but monitoring body weight, colon length, and intestinal permeability, which is, of course, one of the prominent functional responses in the epithelium. In each of these cases, the HIF-1-alpha null animals resulted in a quite significantly increased disease process. In fact, many of these animals in this case died during the induction of colitis. So this suggested to us that HIF was, in fact, a protective mechanism, transcription factor that was elicited that was protective under these circumstances. So a couple years later, we then began to think, is it possible then to stabilize HIF at a tissue level and elicit a protective response? And to do this, we developed inhibitors of the enzymes that degrade HIF-1-alpha. So Peter Radcliffe had discovered the PHDs, the prolyl hydroxylases. Those enzymes could be targeted. The way we did this, so the PHDs were originally discovered, as I said, by Peter Radcliffe. PHD 1, 2, and 3 are highly, highly conserved molecules between mouse, rat, and man. And the way we did this is we targeted these molecules with either oxoglutarate mimetics, so this is the cofactor here is oxoglutarate, or using iron chelators. In this case, the PHDs are iron-containing proteins. By chelating those iron molecules, they can no longer bind oxygen, and this functionally inhibits these molecules. So one of the commercially available molecules is DMOG, and this has been used widely then to study the PHD inhibitors. We worked with a company in San Francisco to develop some molecules, and in this case, the FG compounds 4497 and 4442. And you can see here that just by looking at reporter assays that at submicromolar concentrations, these molecules stabilize HIF. In the presence of oxygen, or in the presence of hypoxia, this becomes enhanced. The structure of FG4497 is shown here. It's an isoquinoline-based molecule that functionally blocks the PhD through the chelation of iron. So what do these do in vivo? Well, in vivo responses to these HIF stabilizers, you can see here that by giving either IV or oral FG4497, that plasma EPO levels go up, that hemoglobin goes up, and that hematocrit goes up. So these are molecules that regulate EPO, obviously. EPO is one of the targets. It's actually a HIF2 target, but it's a very, very prominent target. HIF was based on this regulation of, originally discovered based on its regulation of EPO. So we had to be careful, some of these initial experiments, because we saw hematocrits of 60 to 70 in some of our mice. The people that like these are these guys here. It's been termed oxygen in a pill. The first 3 athletes have been busted with these drugs as they become more and more available. There have been a couple of runners and even a race walker that was busted for taking these drugs. So the Olympic committees know about these molecules. But so if we go back to our colitis models then, just by monitoring body weight, this is one of many pieces of data, but just by monitoring body weight, the first thing you notice is that the severity of disease is quite significantly diminished, and the recovery from disease is quite significantly enhanced in the presence of these molecules. Histologically, this can be shown here. Here are vehicle-treated animals. TNBS colitic animals, you can see the structure of the tissue is quite significantly changed, and in the presence of this drug, while not normal, clearly these molecules show a favorable response in this mucosal inflammatory model. So we have not been the only ones to make these observations. It's now multiple papers over many, many years that have suggested that the lack of epithelial HIF-1 alpha, the use of PHT inhibitors, all appear to be protective in the mucosal tissues. And how do these do these? I'll just summarize this with this final table, and that is there are many, many target genes for HIF in the mucosa. Some of them are very unique to the mucosa. For example, some of the molecules that Chris was just talking about, MUC3, which is one of the inducible mucins in the gut, and cross-linkers of mucins that promote barrier function. We know that adenosine metabolism, so molecules, or the enzymes in particular that regulate adenosine metabolism, are strongly regulated by HIF. Tight junction proteins, xenobiotic transporters, a number of leukocyte adhesion molecules are important. Creatine kinases, some of the defensins, and some of the integrins. So these are all target genes that have been demonstrated, documented very well to be HIF target genes in the gut. So I'll finish here with a model that we believe that adaptation to metabolic changes in the gut is probably very, very important in inflammatory disease, particularly under inflammatory, this terminology of inflammatory hypoxia. So one model suggests that as leukocytes move into the tissue, they consume oxygen, lower this oxygen level at the level of the tissue, elicit the response to HIF, and we think that the primary function of this transcriptional regulation is really to promote barrier function, to promote healing of that tissue, and we think that this is really a therapeutically targetable pathway in the intestine. So the people that did the work, this is an older picture of the lab, of course, but I mentioned Eric Campbell, Louise Glover, a number of these people are sitting in the crowd today, and then all of our collaborators from throughout the world. Thank you very much. Right. You know, in the gut, which is actually a pretty mature field for stem cells now, in the gut, it's actually they're surprisingly little known. We have all of the mouse models right now, and we have samples up and going. I think probably at least based on our initial observations, HIF1 and HIF2 may be somewhat redundant. So knocking out one, there may be compensatory pathways. The one thing we have noticed is if you knock out the heterodimeric partner, HIF1 beta, that the cells cannot be passaged. So it seems that you can establish stem cell cultures, but they probably cannot be passaged. So that's a pretty good indicator. We don't know the basis of that, the molecular basis of that as of yet, but clearly, you know, I think you work in the bone marrow, where the bone marrow is also one of the more metabolically active tissues in the body. So I think clearly that's an area that's important. Well, to be very honest, it's probably it's a good thing is HIF is actually a really hard molecule to inhibit. It's much more easy to stabilize it because you can inhibit an enzyme. When HIF was first discovered, it was thought to be probably the savior. It was thought to be it's going to be a silver bullet because you could target HIF and then block cancer, starve a tumor, kill a tumor. That has not proven to be the case. So there really are not, I would say, effective HIF inhibitors out there yet. Lots of screens being done and lots of pathways being targeted, but most of them have proven to be pretty nonspecific. Thank you very much.